Hello, everyone, and welcome back. We're going to do a clinical one today. It's been a minute. So, this patient came to see me in December and had the traditional orofacial pain signs. As you can tell, she ended up coming back and getting the root canal done. So, what happened here, we had adjusted her quite a few times. She had the crown prep done back in November, and they had been adjusting her bite quite a few times. She ended up coming to see me in December. The tooth was vital at that time. We did the adjustments, but she was like, I'm still having pain. So we did the adjustments and gave her a couple of weeks, and she was feeling better, and it ended up getting the crown permanently cemented. Ended up coming back a few weeks after that and decided, the pain is too much. Let's go ahead and access it and go through it. So for those of you who were at the lecture in Hawaii, I talked about this. If you wait too long, the analogy my friend Raheem has used, it's kind of like having a pot of boiling water on the stove. If the pot of water is at 212 degrees and you turn the heat on underneath to maximum, the pot's going to boil over, and it doesn't matter how much work we do to get it to kind of go back down to normal, it's not going to. If, however, we can get that pot of water down to like 100 degrees by using something like a steroid at the time of the crown preparation, sometimes we can get these to not boil over. It's why if you've ever had those patients, for the general dentists out there, those patients who say, hey, every time I have a crown, I need to have a root canal, this might be why. If you want to have more information on this, I have hours of lecture that I've given to the residents on this very topic. But this is what started off my journey down the what's going on with these cases. This is where, if you've seen me talk about my brother's case, where there was that number 2 where I accessed, and it looked just like this. This is a case where the tooth looks pretty darn normal. That is not an angry tooth. That's a bleeding that looks normal, but the amount of pain she was having, 10 out of 10 pain, she had been dealing with this for, at that point, 3 months, and she just was begging me, please fix the cold sensitivity. So we, at that point, accessed the tooth. As you can see, we kept the hole very, very small here. Didn't need to make a large access because this wasn't really that calcified of a tooth, and we can keep everything very tiny. She just had this zirconia crown placed, so don't need to do too much here. This will go into the lecture that I don't know the order I'm going to put these in, but the lecture that's coming out either before or right after this one will be on how to access calcified teeth, but how to find MB2. We've already found MB1. I'm going to use the skinny diamond here to just do a small little troughing between MB and palatal, and this is exactly what it looks like in real time. As you can see, this case did not take me very long, like 20 minutes with the cuts. I mean, maybe a little bit longer here with x-rays and everything, so probably 25, 30 total minutes. I cut out some of the boring stuff that you guys don't want to watch, but the whole case does not take that long. You'll see there is a little bit of inflammation in the palatal canal, but on the buccals, pretty much a normal looking tooth, all things considered. A little inflammation there, but the buccals look very, very normal here. And that goes to show, even though the tooth itself wasn't inflamed, if the patient is inflamed, it's going to cause a lot of pain. And that's where the tooth kind of boiled over, and that's what caused her pain here. And yes, we gave steroids. Yes, we went through the whole process that we've talked about many times. We've adjusted the bite. We gave her exercises. I think we even gave her a night guard in this case, and she ended up being okay in the temporary. But once she got into the permanent crown, even though we had adjusted the bite, she ended up finally having so much pain. She just was asking me, please access the tooth, get the tooth out of pain. And so here we are. Anyway, need to do a little bit more work to grab that MB2, and I'm sorry about the small access hole. Doesn't make for the best video, but I figured this was a good combination for the new viewers who joined after the Hawaii lecture, talking about exactly this case where you have a patient who has some of those hyperinflammatory symptoms, coupled with my other viewers who just watched the lecture on how to access teeth. It's kind of a good 1-2 combo case to bring everybody together. But as you can see, not the most inflamed looking tooth. For those who haven't done a ton of root canals, normally when you access a tooth where it's a 10 out of 10 SIP case where it's completely irreversible pulpitis, as soon as you access into a case like this, it is blood coming out the top, boiling over. And you can see it doesn't look like that. I don't know if you can see, but right about there, that's where our MB2 is. So sometimes in these cases, it is very, very difficult to see. This is why when a viewer asks, if I'm a GP who's trying to find more MB2s, what's the best technique? Is there, it's get a microscope. I don't I wish I had more advice to you besides just what every endodontist says, but there's a reason we use these, and it's because they're very small. It's hard to see. You can see how easy it was to find MB1, MB2, or MB1, DB, and palatal, but look at how tiny that little guy is. That's very difficult to see without the help of this. And after finding, this is my technique by the way, after finding with the little 8, we're just going to use a 1704 to open up that first little bit. And what I'm doing here is just based off of feel. That's why the video is not very useful here. It's just kind of going until I start to feel some resistance and then backing out. And you'll actually see when I dry this area, it has created most of the shape for me. Sometimes we have to do a lot more work as far as troughing. Sometimes it actually does the work for me. And here I'm going to be able to go in with my 2006 and actually have it do the rest of the work. It met a little bit more resistance than I wanted to, so I decided to go ahead and stop at that point and rinse. And when we're using rotary files, this is a question we get often, is how do we use the rotary files? This is, I've mentioned this before, but Brad Gettleman was one of my mentors way, way back in the day. I actually went to college with my parents, which is random. But the amount of pressure that you want to use is just enough that you would break like a pencil. So it's not a lot of pressure. And how I like to use it with these heat treated files is I don't push enough. You want to push just enough that it's right before they would start to buckle. And with these really skinny files, that's not a lot of pressure at all. So you're almost going to just be using the file to carry itself down. And so it's really very light tactile pressure, if anything, and let the file do the work. Sped up the working length. You guys all know how to do working length. It's pretty straightforward there. But that's it as far as the cleaning and shaping. And so when we talk about breaking things up into smaller segments, that's pretty much it. That was it for the cleaning and shaping aspect of it. And now we're going to get ready to obturate. So what we're doing here is the final rinse portion. Another question I had recently was how much do you need, or how much rinsing do you need to do? And it's going to depend on how much antibacterial stuff we need to do. And in this case, this was a vital case. So I'm not as worried about killing bacteria necessarily. It's more getting the vital tissue out of there, which bleach does a great job for that. And I'm using Triton here. So you can see we're creating a lot of bubbles, which makes me happy. And we just want to rinse until there's not any bubbles left. That's kind of my rubric. If there was still bubbles coming out, it means there's still organic tissue, and so we'd want to rinse a little bit more. But at this point, after running through the rest of the Triton here, the bubbles pretty much stop, which means there's not a lot of organic tissue left. And since there wasn't a large infection in this one, I'm not worried about having to medicate or anything like that. If you're really, really worried about teeth being infected after, you can always just medicate and then go off of the patient's symptoms. If they return after a month or 2 weeks or whatever your time period is, and they feel great, well, then you can pretty confidently proceed with knowing that they're going to be okay. And if you're worried about it, there's always enhanced irrigation. There's not a one-size-fits-all model for teeth because we work on patients, and patients are difficult. They're different than teeth, and that's what I think a lot of the research that we do misses. Sorry for getting on a little soapbox there, but yeah, it's a longer answer than, always used 9 cc's. That will fix your problem. I wish I could give you that answer, but it won't. Anyway, so I do like using the activator, mostly because the reason I like using the endoactivator isn't because I think it makes a difference for the outcome. It's actually because it makes my obturation technique easier. Because it knocks debris off, it makes it so that the gutta percha flows more easily. If I wasn't doing the squirt technique, I probably would have stopped using the endoactivator a while ago. But it seems when I haven't used it that the squirt technique binds a little more readily, and that's why I still use the endoactivator. I don't think it makes a difference at all as far as the outcomes from an antibacterial standpoint, and I think that's one of the ones that actually has been shown pretty clearly in research, is that it doesn't seem to do a difference at the sonic level. So there's your endo fact of the day. Anyway, at this point, what we're doing is just getting everything nice and dry and getting ready to seal it up. So there's our MB1, MB2. As you can see, this one actually was pretty straightforward. Once I found the MB1, the rotary files are actually able to do most of the access for me. Sometimes that's not the case, and you have to use something like the diamond. What I did find here was I thought there may actually be an MB3 that I needed to get into. Sometimes after doing all the cleaning and shaping and getting everything nice and dry, you may notice a little bit extra. That's the sure to strike fear into the heart of every dental assistant is after we've done all this work and then I ask for an 8C, they're like, oh no, he found an extra canal. In this case, it was just a small little tiny fin. There wasn't an extra canal. So we were able to continue and finish this case up. No problems there. Little bit of bleeding from that palatal still, but you'll see we get this nice and dry. It was just a little bit of extra, but so maybe she did have a little extra inflammation in the palatal, but the 3 buccal canals were completely normal there, looking okay. There was a small crack going down into the palatal too, so this tooth probably was going to end up needing a root canal, all things considered, but yeah, kind of an interesting one showing just how teeth are weird. After doing this for so many years, I think that's probably the best thing I can say. All right, we've had a lot of questions recently on the squirt technique, so after getting the canals very dry, that's important, you then apply your sealer. I like using AH+. BC is a great, any of the bioceramic sealers are great. However, most of them will set up instantly and heat. And so as soon as you inject the gutta percha in there, even the high flow, yes, it will usually cause you to have a short obturation. Ask me how I know this. I then recapitulate down to working length with a K file. Sometimes it just drops down like you see there. Sometimes I have to work it up. Sometimes that's watch winding. Sometimes I'll use a 15. Sometimes I'll actually go back with a 10. If it doesn't go all the way down, I may have to use rotary files again, but you want to make sure that you have a pretty passive fit to your working length, ideally with a 15 or a 20K file. You're going to then place your beta, in this case, or you can use Obtura, whatever it is. I would use a high flow gutta percha at the highest temperature that you have, and then use the smallest gauge tip that you have available to you. In this case, I use the high flow gutta percha from B&L. I've used that one forever, so I'm very familiar with it. Consistency is key here too. You don't want to try out different ones. So once you find one that works, keep using it so you don't have to learn a new system. I use it at 230 degrees, and then I use the 25 gauge multi-bending needles. I've used these now for, how long have I been doing this squirt technique? What, 6, 7? Oh God, I just did 6, 7, sorry. I've been using it now for quite a long time and gotten to the point where I can pretty well determine how much pressure to use. Some people, which totally works as well, like to use a gear or motor driven system because they know that it always gives the same pressure. That works too. I like a calamus system. I've never liked the calamus, so I don't. But I know people who like to use that technique with the calamus. If that's you, go for it. But people want to know what I do. There it is. Then the next thing is to use the plugger. Make sure that it's a nickel titanium one because you want it to be flexible. And after you inject the gutta percha, wait until it starts to push you back. And then at that point, stop and go back in with your plugger and give it some apical pressure. You're going to want to vary your apical pressure based on the size of the canal. So something that's wide open, like you can see right there in the palatal, it drops a little too readily, so you don't have to do as much pressure, whereas something that's skinny, like those buckles, you actually need to do a little bit more pressure and kind of vary it up. You want to be careful with retreats where you have large apical sizes. You also want to be careful with any case where there was a large lesion or infection. What you're doing here is you are relying on the pressure that is present inside the bone to give you back pressure. In those cases where you had an infection and now you've cleaned it out, there is no back pressure, so you run the risk of shooting a bunch of gutta percha out the end. That's a risk that you're going to have to be willing to take. And then at that point, kind of down pack, and then backfill with the rest of the beta unit. I would recommend trying this on like a maxillary premolar that you've shaped to like a 2504. If you're just starting this off and just starting down your minimally invasive journey, that's a really easy shape with a really easy like canal to do it with. Don't try this with a wide open number 9. That's a bad idea. Unless you want to do some apicos after. that would be probably the easiest one to do it with. Also, be careful with any type 2 canal system when they join, because that's where they tend to kind of go back up the other canal and you'll end up with some short fills. I often end up having to do a traditional warm vertical approach there because it'll go back up. Anyway, if you have more questions on the squirt technique, please drop them below. I always said I wouldn't teach that, and I get more questions about that stupid obturation technique than any other question, because I decided to mention it once in a stupid video, and now here we are, many years later, and I get more questions about than anything else. Anyway, let's go ahead and finish up this case. I ended up being happy. We took an x-ray there. Everything looked good, so we're going to seal this up for her. Thankfully, we're able to keep the access nice and tiny, nothing too hard here. So zirconia crown, we're going to end up just doing a quick little sandblast to roughen up the zirconia, give something to bond to. In this case, though, the access is so tiny, I'm not really worried about this thing dislodging. That's not how this tooth's going to fail. So the composite's not coming out of this thing. This is even GB Black would be proud of this access, because there's a lot of mechanical retention here. That's not coming out this way. Sorry about that mirror. This is the cheap mirror that we use for all of the sandblasting, because they're cheap and they're designed to get blasted to pieces when I do this. You can see the difference in the reflection between the nice photo mirrors that I only use for my pictures there. So I do have 3 different mirrors, in case you're wondering. These are the size 0 ones that I use for pretty much everything else. And then go back in with our bonding agent and get ready to seal everything up here. I do use a dual cure addition to the bonding agent, just to make sure that it's compatible with the dual cure build-up material, which in this case is just going to be Luxicor. Seal it up to the top. I know there have been some back and forth about can you use it with it. I do have a nice 10-year recall of a Luxicor in an axis just like this that has been going strong with no leakage, no problem whatsoever. So it does seem to be working great as far as the recalls on this. So I know lab studies are one thing, but clinically it seems to be working just fine here. So seal this up. Unfortunately, the staff decided my hands needed a workout, so they gave me the teal blue Centrix tube, which is awful. For those of you who don't know, this is the smaller gauge one, and you have to push a lot harder. I like the brown one because it's a much wider gauge, easier to push. You only really need this one where you're doing posts and have to go down canals. So yeah, smooth it out with the glick. Yeah, the occlusion thankfully was rock solid on this one, because we had seen her a few weeks prior to adjust the occlusion on it. And yeah, that's when at that point I told her, I was like, look, we'll adjust it one more time, give it a few weeks. If you're still having pain, we'll do the root canal for you. And she said, please do the root canal at this point. So thankfully, the rest of this video is quite straightforward, but I figured this would be a good one to show everybody. It shows the MB2. It shows sometimes with our myofascial pain patients, the hyperinflamers, you can't fix them all. And it's really important in these cases to remind them that they always have an out. So one piece of advice: start by trying to keep the tooth alive, but always give them that out and say, hey, if you do need to pull the trigger and say, do the root canal, I'm here for you. If the pain gets too bad, I can always fix that cold sensitivity, but I might not be able to fix that biting pain. So just remind them they do have the out and that out issue. Anyway, here is the final post-op. Happy with how that all turned out. You can see the 2 MBs there. She was happy. She's out of pain and thankfully didn't have any biting sensitivity. As always, thank you so much for watching. If you have any questions, drop them below and I will talk to you all next time.